It's 10 o'clock, so we'll try to get started. So I can check off who we got here in the room. So do we know who's online?
Pete's online.
Okay. Pete, how are you, sir?
I'm fine. How are you?
Well, very well. So I don't see Lee right now, and I don't see Vic, and I don't see Blake.
Vic's not coming out.
Okay.
And Blake, I'm not sure.
Yeah, Blake,
Does anybody have an update on him? We've not heard anything.
he was on TV the other day. But he was looking fairly good, but I haven't talked to him. I need to call him. And make sure I know what to do. But Blake has had some pretty significant medical issues going on. All right, well, I'll call a meeting to order, and we do have a quorum here. I appreciate that. You were sent minutes electronically, and I would entertain a motion to either approve or amend the minutes.
Motion to approve.
Have a motion to approve, have a second from Jeff. Any other discussion? All in favor be aye.
Aye.
Any opposition, same sign. Mr. Oliver has arrived. Liz, I think you're up.
Share real quick.
Morning, sir. Sir, how are you? Good about you?
This is just my very brief overview. I'm just going to focus my comments today on the ACS trauma system consult and role focus review from last week, because obviously that has been much of the focus of our attention for the last 6 months, was preparing for that. And we had some really great recommendations that came out of that. There will be a lot more information for us to push out, but I just wanted to hit the highlights of this for you. And so there were, the way the ACS does this is they give you priority recommendations. And then, so those are obviously the things that they feel like we would be best spent using, maximizing our efforts in those areas. In addition to the priority recommendations, there's a whole host of other recommendations. The document, if any of you looked at the 09 system consult document, there were almost 100 recommendations, I think, from there. So it's pretty big. And I think also, if you've not looked at the newest iteration, and I say newest iteration because they're what they call essential trauma system elements document was just updated in November. And that's the first time in about 10 years. Actually, Dr. Ashley and I were very privileged to work on at the national COT level on that document to craft the recommendations. So let's talk about the 14. They said 14. It doesn't look like 14 here, but I think they had a couple of them per slide. So I tried to coalesce them so we could just kind of hit the high notes. They had 14 of the priority recommendations. And the first one I'm gonna noodle over a little bit because I think perhaps it's probably the biggest one that we need to work on. And when I say we, I mean between the Georgia Trauma Commission and DPH Office of EMS and Trauma. So, and this also came up on our 09 review, is that we should, as a state, either identify a single lead agency or develop a crosswalk that defines the responsibilities in the Office of OEM&CT. And I have to say, in talking with our partners and looking over the code that established us, and listening to Dr. Ashley very elegantly kind of talk about this, is that in the midst of what was a crisis in our state back in 09 when they came in before, the commission was just established 2 years prior to that in 07. And literally, and it was a great piece of legislation, but essentially they just dropped this commission out of nowhere into legislative code. And there was a lot of duplicative authority recommendations and powers that were included in that code. But nowhere was there any You know, like you do this, 2, 3, 4, we do that, 6, 7, 8, you know, there really was no delineation of who did what. And so I think it's fair to say, Lily's back there nodding her head, it's fair to say that there over the years and with changes in leadership in my role and changes in leadership at OEMS&T, there has been quite a bit of confusion and consternation resulting from that confusion. So we have to clear that up. That is a significant problem that has existed for 14 years. And it has to be dealt with. So we're committed, Dr. Ashley's committed, Xavier Crockett, who's the DPH Division Director over Health Protection, Kelly, Michael, the entire OEMS&T team, we're ready to work together. It's a new day, it's new leadership, and we want to come together and figure out how can we make this better for the state. We don't want confusion. We want it, it's bad enough that we live in this murky world with a lot of ill-defined things for trauma. Because Courtney will say firsthand, you know, trauma is not stroke, it's not STEMI, it's not cookbook. Therefore, a lot of confusion exists with regard to clinical care. We don't need to have that bleed over, no pun intended, to our leadership infrastructure. So we are committed to changing this. I will say that. Well, we have the right team to do that now. So the next priority recommendation bucket was funding. And so they wanted us to conduct a new study. We've done a lot of studies. I'm a little worn out when I hear that word, to be honest with you, but to determine what the true financial need is to sustain and advance the system and statewide EMS. We estimated earlier, probably 10 years ago, that it would need about 80 million. We get about 22 million a year. There's a huge gap that exists there. It's probably now well over 100 million. We've done a lot of needs assessments with the trauma centers, but we don't really know from an EMS perspective, and we know we have huge gaps. We discovered that in those 3 days, particularly with respect to South Georgia. So we have to learn how to crack this nut a little bit and figure out what that cost might be. So with that, once we determine what the actual financial, the whole picture need is, we need to obtain a dedicated funding mechanism for the Georgia Trauma Commission. You all have heard me talk about last legislative session when we got the Georgia Trauma Trust Fund established. So luckily we at least have a fund now where dedicated monies can go into where they didn't before. So now we're guaranteed to get our super speeder and our firework money, and it goes directly into the trust fund. With the funding also, they recommended that we evaluate existing funding to develop and sustain rural components of the system. We know there's a disparity between what some of the urban areas get, particularly with respect to, we've had the same trauma center funding allocations since the inception of the trauma center funding, since 07, 08. So even though we don't, you know, we certainly don't want to cause pain points at the tertiary centers, because especially those of you living in the rural areas, you know, your patients have to go there. So we don't want to rob Peter to pay Paul, so to speak, but we need to look at a more equitable funding distribution methodology. The third recommendation was the multidisciplinary trauma advisory group. We've talked about that for a number of years. This is something that in partnership with OEMS&T, we will work on getting together a multidisciplinary advisory group. We have nuts and bolts of this in various, if you look at all the advisory committees for EMS, regionally and from a statewide perspective, MSAC, MSTAC, et cetera, it goes on. And then the commission has various committees. In all these years, we've been missing rehab from the picture, right? And a lot of the trauma center bottleneck comes with trying to get patients to rehab. Patients lay around for 3-6 months without being able to get out to rehab. So we need to bring partners like that to the table to help us really, you know, kind of figure out some solutions to some of the problems that plagued us for a long time. Our trauma system plan, while we have one, it's quite dated. It's from 2015, 2016. I bet none of you know that it exists. It does not live in a way where it's easily accessible, and it doesn't address all of the components of the system. Namely, there's no performance improvement plan. There's nothing that says that we will monitor this and we will do this if this isn't met. There's nothing that describes how we should perform and targets that we should strive to hit. EMS, I think you guys are gonna love to hear this, but they felt like we need to declare EMS as an essential service and establish a funding mechanism for sustainability. So we're gonna look to this group and really dig deep. I know with our other partners in the room, we need to really figure out how to bring this message forward. You're all living in this world and it's not only tough, I think the survey team heard loud and clear all of the problems with recruitment and retention of your workforce, in addition to your dwindling reimbursement and inability to maintain adequate service levels, particularly in the rural areas. System triage and patient flow. This was noted in our 09 review. I know this is probably not a popular recommendation, but I would say we're really going to improve things. We have to approach it from a systematic way, in that we need to develop some standardized regional destination protocols, including what are we using our level 4 trauma centers for? I think most of you would say that with most of your patients, you would bypass the level 4. We haven't really established what the role of the level 4 trauma center is in our system. We haven't done a great job with that. So we need to really understand what their capabilities are. And we may need to we heard a lot over the few days about this idea of where you stop and stabilize and then move on. You don't dump the patient off and then leave. You stop, get the airway, get the IV access, throw some blood in, and then hit the road and go to the tertiary center, because most of the patients are going to have to be transferred out. Many of our level 4s don't admit patients. Some of them do, but most don't. So that's noted from our 09 review. So that's something that's been around for a little while that we'll have to address. Another thing that sometimes is a little hard to think outside the box, but to develop this regional medical operational control command structure statewide for resource monitoring, patient transfers, transport, and load balancing. So this is when we use this this example quite commonly, where the Macon, Savannah, and Augusta area, if one of those goes on diversion, they're usually texting the other one to say, hey, we've got an issue. And we just talked about, Dwayne and I, where Navison had to go on diversion Saturday because they had some issue with their operating room where they were fixing some environmental control issues. So they had to close down for a whole day. So what was the plan for that, right? We don't have something in place where somebody can stand up with the authority to say, this is what's going to happen in the region and adjacent region with critical patients in this time when this one center is closed. I'll tell you, the best thing we have right now is a WhatsApp contact list with all the trauma medical directors. So if they have somebody really sick that needs to get out, they can do it. And WhatsApp has worked over like COVID, but it's not a long-term solution. We need something a little bit more sophisticated than that. And then with respect to definitive care, the recommendation was to develop performance measures to monitor the designation process, including compliance with criteria, application processing within 60 days. I'm not really sure exactly what that means. I think there might have been some confusion about the application versus the disposition. Systems to ensure that the facility completes designation review every 3 years. And again, working with the partners in Office of EMS and Trauma. I think they're dedicated to working through this and making sure. I think in years past, just in transparency, we've fallen a little bit behind, and that probably has a lot to do with the misunderstanding of the role of the level 4s, because when the level 4s had an extra consult review, we found that there were a lot of tracking in the level 4s, and unfortunately, I can attest to my role in a trauma center. When you don't have someone from outside your building coming in, telling your C-suite, telling your leaders what needs to be done, it doesn't get done, and it goes low down on the priority, and so therefore it doesn't get done. We've had a lot of centers that not submitted data in almost a year, and that a lot of that has been corrected, but it was a chronic issue. So we need to make sure we don't get in that place again. In terms of the trauma system registry, that's the data warehouse for the trauma patients meeting trauma criteria. The recommendation was to develop a collaborative stakeholder data use work group to define the needs required to evaluate and manage the trauma system. Again, we have some bones of that, but we really need to kind of take a look at what does that mean? Again, incorporating the entire continuum. We have a lot of trauma out. Gina's whole position revolves around outcomes measures in terms of trauma center, but we need to kind of look at what are those EMS performance measures? Again, what are some of the rehab performance measures? And then disaster preparedness. So this was a huge one. Again, we have such great things going on around the state, but we don't have one sort of repository. The recommendation was to develop at the state level, multidisciplinary disaster planning group that includes, but not limited to, representatives from GMA, DPH, the hospital the coalitions, regional coalitions, RTAC leadership, and other trauma experts, to include the leadership of the regional coordinating hospitals, EMS stakeholders, military. Military was a huge piece, sort of like we do integration, and those other folks and resources. Management of multiple trauma patients. And then also they wanted to see those disaster preparedness plans integrated at the RMOC level. So that regional medical operational command, where again, when you have a crisis, a center shuts down, 2 of the 3 centers shut down. Again, in that case of Navicin, Savannah, Augusta, while Navicin was on diversion, and Savannah goes on diversion, we know Augusta is going to become pretty quickly overwhelmed, right? So what happens? Well, there's just no connecting the dots there. So those were the priority recommendations just from a system overall, system perspective overall. And then there were several priority recommendations for rural, and I'll run through these fairly quickly. To perform a comprehensive resource needs assessment, including funding for the rural trauma system, emphasizing the rural aspect of EMS and trauma hospitals. Rural capacity needs to identify gaps, including EMS, trauma hospitals, and transfer capabilities. Recruitment and retention, focusing on rural providers, nursing, and EMS. Involvement and participation of the rural hospitals and EMS in an inclusive Georgia statewide trauma system plan. I think when we talk about inclusive, we also talk about non-trauma centers. You guys know firsthand when your crews call a non-trauma center, a lot of times they're waved off. No, keep going down the road to the trauma center. They have a role in the trauma system. We need to kind of figure out what that is and how we pull them in. Standardized trauma care in rural Georgia, utilizing educational programs. I think we do a great job with a lot of that. We could do more, it's obvious. Increase rural emergency medicine providers and resources to provide the capability to manage traumatically injured patients. Improve scene response time by bolstering existing mutual aid agreements and addressing staffing shortages. There was a great, Jason stood up on day 3 in at the Northern Georgia review and talked about his reliance on mutual aid and what their agency was sort of doing about that. And that was a great example, and great that he was willing to sort of talk about that. Develop a process for rescue stops and accelerated transfer in rural areas. That's what I talked about we're going to stop at this hospital. You're not going to go out the door with the truck. You're going to wait until whatever the patient needs they get, and then just continue on. And, you know, there would be like a sort of auto acceptance criteria where the receiving hospital would know about that. And so they would agree to accept under whatever circumstances. Provide education and collaboration for rural facilities to achieve proficiency regarding data entry and validity. I think in the trauma registry, what we're finding is that in the level 4 centers, particularly because of the turnover, as you guys all know, we face it too. It's hard to get really good at coding injuries, and coding injuries is something that if you do it 300 times a year, it's hard. If you're only doing it 20 times a year or 40 times a year, it becomes really difficult. It's probably not accurate. And that's just the facts. So we have to really figure out. We're working on that through some education with the registry staff and mentoring. And then provide rural trauma program managers process improvement training, along with mentorship and support from other facilities. That has already started. We identified that as a need very early on after the level 4 console visits. We realized that we needed to spend a lot more time in that space with them and really help them and try to pair them up with mentor facilities. And we're creating a whole separate track for them at our March meeting. So I hope we're gonna be able to address those needs soon. In addition to what I just read to you, there is 89 additional recommendations for the system as a whole and 29 additional rural recommendations. We should get the report in another 7 weeks. We have about a week to respond to any inaccuracies that we need to have them changed. And then within 2 weeks after that, we should have the final report. So in about 9 weeks, we should have the final report. We will post that to our website. And for any of you that were there, for folks who were there, I definitely would like to release the draft reports so we can make sure that we have more eyes on the final product so that we make sure it's accurate so that we can address all of these. And I'll stop there in case anybody has any questions, but I'll leave it up.
How many of y'all had an opportunity to participate? Okay, thank you. I was real tickled at Trauma Commission. All of the commission members participated at, and for some of those folks, it's pretty difficult to break away. Overall, I thought it was an excellent event. I don't know what else to call it. I learned quite a lot. One thing I at least perceived, I went to all of the South Georgia and North Georgia. I perceive a lot of differences in needs and resources between the two. That may be just me because I looked with rose-colored glasses. I don't know, but that was the way I looked at it. From my perspective, one of our biggest issues, well, we have two different things that I have issues about. The first one is the ability to have enough people do the job. That is across the state. That's not just rural, that's not urban, it's across the state. If anybody, I'm sorry, Tim, I'll try to do better. I think there are some pockets of our state that are very good with EMS staffing, but I think that those are the exceptions rather than the rule. And I think it is continuing to be a challenge. I don't know if I sent all the governor's healthcare workforce task force report. Have y'all seen that? I will send that to you. I apologize. I was on that group and we worked for quite a few weeks, met quite a few times, discussed a lot of issues with all, with physicians, with nurses, with allied health, with EMS, behavioral health. And what they did was they broke out, they had a main section and then they had a section developed dedicated to EMS needs. And then they had a section developed to specific behavioral health needs. I don't know if the two of us have that much in common. I don't know. But there were some, they recognized some definitive issues with EMS and the need to increase the workforce. They recognize the fact that a lot of EMS agencies today are doing their own training as opposed to the technical colleges that used to do it years ago. So it becomes a different sort of a burden. So if you have a technical college that's doing good work in your community, I think that's a wonderful thing. We just need to get more of them involved in it. And for them, I think it comes down to just exactly what it comes down to us. It's a economy of scale. If you don't have enough students coming in to do it, can you afford to do it? So we got those recommendations have gone to the governor, and hopefully we will see some of those start bubbling up. I would encourage you to read that. Have y'all seen the level 4 trauma assessment? Has that been sent to them?
No.
Yeah, we'll send you that too. There's a lot of commonalities in the 3 documents. All right, so I would encourage you to read those. The other piece that I was alluding to a while ago is the ability to transfer patients timely. And I spent a good bit of my time on the phone with a couple, three rural hospitals who have huge issues getting patients transferred out. And they are dependent in their rural geography, pretty much dependent on the 911 provider because there's not a private provider in that immediate area. And at least one of them, the government agency, the 911 service, has 5 full-time employees. And they can't hire anymore. Now the hospital now is looking to start their own ambulance service just to do transports. Now, whether that will be financially feasible for them or not, whether they can pull that off or not, I don't know. The hospital has reached out to the technical school about starting a program in their high school about doing, they asked me for grant money and I checked with Kathy. Turns out the EMS in that county already had a grant to do a class, but they can't find an instructor. So there are a lot of issues. My goal as a member of the Trauma Commission is to figure out a way that when somebody in any area of the state has a critical need to get to a level 1 or 2 trauma center, that the resources are there. I have had folks who said, well, we just need to require the 911 zone provider to do that. And unfortunately, in many cases, the 911 zone provider doesn't have the resources. And in some cases, even if they did have the resources, because our hospital is a referral center, then we would be mandating them take care of patients from half a dozen other counties, which is a problem financially for them. So I don't have the answer, but I hope working together we can come up with this. I hope that this will become a priority at the Capitol and that the legislators, what I would love to see is a joint House Senate group look at EMS. It has changed. I made a comment at the meeting that it was designed in 1966 to pick up patients in the ditch and take them to a hospital. And the systems have changed. The funding stream for EMS continues to be pick them up, take them to a hospital. So I think we need to be some changes. Any comments? Okay. Thank
I
you,
saw
Liz.
Jeff, your eyebrows raised at that
Can you send us
stabilizing
that?
transport. Yeah. Oh, yeah, sure.
Put that out there.
So one of the things about, if y'all heard my story, I'm sorry, you have to hear it again. Kid was 18 years old, took a 38 caliber pistol, put it to his chest, pulled the trigger. Shouldn't have done that. Made a damn nasty hole. Our policy was designed, my policy, I wrote it, was designed through the American College of Surgeons. You know, critical trauma goes to the highest level of care. That's a level 1 center. Level 1 center is from Emmanuel County. Is probably an hour and 15 minutes if the wind's blowing right, to an hour and a half if it's not. So my medic brought him to Emmanuel Medical Center, which is a level 4 trauma center. I was listening to it on the radio. I got up, I was on my way over there to clean his clock. And I asked him, why did you bring that patient here? One of the few times my brain worked. He said, Courtney, I could listen that long, it's full of blood. And I knew in an hour and 15 minutes, that other one would be too. So the doc put in a chest tube. They started some more blood on him because he'd done lost a whole bunch. And the kid's somewhere in Emmanuel County today, a couple of years older, hopefully a little bit smarter. That's what we got to do. And we've got to, if any of you have taken a patient to a rural hospital, what's the first thing they ask you? Why the hell are you here? And we have got to get it so that the EMS folks and the hospital folks are on the same task. And one of the challenges I'll talk about in a minute is trying to bring those rural hospitals up to where they need to be. I was very proud of, and all I could do was tell that medic, I'm sorry. You know, I'm sorry I put you in a bind where I had a policy, you had to break it. But my other point is we got to figure out a way to make sure all of our paramedics, our EMTs have the capability of saying, this kid won't make it to the level 1 center. He needs an airway, or he needs blood, or she needs whatever. And that when they call a rural hospital, that they know that, and they have the capabilities of putting in that chest tube or hanging that blood and moving that patient on. Now, I did say I said it in the urban, the rural, northern, not urban, northern Spain. One of the things that hinder us in doing that is that if the rural hospital accepts the patient and they're trying to take care of them, and they call up the level 1 center and say, oh no, we can't take your patient. Now they're trying to figure out what to do with that patient. So that there's a whole bunch of pieces to the puzzle. Anyway, any comment about that?
Yes, Courtney, I have one. I guess after 37 years, you run into just about anything, but I can't recall getting in more public scrutiny than when we bypassed a non-trauma center with a critical patient that had an ABC compromise and went to a trauma center instead. We're talking about lawyers, the whole 9 yards, trying to defend whatever the multiple companies, of course, over the years through consolidation. But once it was settled out of court, and the other times that it was dissolved because we got the right people to come up and stand up for the decision that the medics made. However, I certainly would like to see something in statute that protects a company, a county, a municipality, the medic for making that decision that you're talking about, because even the media got a hold of us for diverting, as they called it, not going to the closest facility to stabilize and going to a level 1 trauma center. And I'll share it with you. The Marietta Daily Journal absolutely barbecued us, my company, for a week, until finally I had to threaten to sue the paper. I had to get Governor Barnes to threaten to sue the paper.
Well,
and
I think,
it stopped. So I'd like to see something. I think it's great, all the different things that the college and everyone is proposing. It's all wonderful, but let's not forget that we are in the worst legal state. We're in the feast place for lawyers, for malpractice lawyers. You read any journal in law, they'll tell you Georgia's the place to go sue. That's the place to open up, to hang a shingle, because it is rampant and our laws don't protect our folks. So, you know, I see this list. I see 89 more things coming. I think that's great. I think we'll look at them, and whatever makes sense we'll do. But let's just remember that we have to protect ourselves, and we have to make sure that the statute and everything else that goes along with it protects the actions that we take.
and I agree, Pete. I don't disagree with what you're saying. It becomes a very difficult, and you can get beat up either way. No doubt about that. I think that the first thing that we can do even without legislation is to come up with those regional protocols on who does what and where they go. Kelly, evidently, you may need to come up here, Kelly.
You can hear me.
Okay.
Sorry. No, and I was just gonna add to Pete's comment. I do think the development of the regional protocols and getting that into place will help. Will it totally do away with your concern, Pete? No, I don't think that will, because anybody can sue anybody for anything. But I think it'll help with those concerns. And I think it would help if we bypassed, and if we didn't bypass, whichever way the EMS crew thought that was the best thing to do at that time for the patient, I think will help with that.
I think one of the other issues, Pete, is if you take them to a rural hospital and they don't know what they're doing, and the patient suffers harm, then yeah, when they sue them, you're gonna get drawn into it too for that decision.
No,
So,
no question, Courtney.
But that goes back to making the inclusive trauma system.
yeah,
Where our non-designated centers, yeah, you're not designated, but you have a responsibility.
any other comment? So next meeting, y'all come up with the solution to our inter-facility transports. All right, whoever does that gets the gold star, maybe two.
Can I just mention about the budget hearings?
Sure.
At the Capitol, the last 2 days and today are really the opening, joint session for budget, and Tuesday was very interesting because it always starts with the governor's report and then, sort of financial analyst, and, it's really great information, and, there's within the last 2 years, the governor created an office under, Office of Planning and Budget called, Office of Health Strategy and Coordination. And they are doing a lot of work to sort of try to aggregate a lot of stuff that's out there, just different things on healthcare, and try to make it sort of a one-stop shop. They did develop this new, it's called GDAC. Lena and I were just talking about this before the meeting started. And I played around a little bit on the website while I was listening in virtually. So one of the things that I noticed on there was they had a healthcare workforce sort of assessment, and they had physicians, nurse practitioners, physician's assistants, and nurses, but no EMS. So I've already emailed them to say, we have some EMS workforce data. Could you help? Could you, if you would really help bring this front and center, if we could include EMS there, they're a vital role. And so I haven't heard back. So we'll see where that goes, and we'll bring a lot more attention. We still have not even been up to the Capitol yet to present anything on budget or anything about our activities with this last fiscal year's funding. In addition to that, the Governor's Office of Health Strategy Coordination also reported on, apparently they were given funding, a budget line item to study behavioral health emergency evaluation and transport. And lo and behold, they discovered that most of those behavioral health transports are happening by EMS, right? Because it's nobody else wants to take those patients anywhere. And there's a lot of trouble, as you're well aware, I'm preaching to the choir, of getting dispositions for those patients. And a lot of times they hang out in facilities where there's no expertise to care for them, and it takes up a lot of time and resources. So, but the study on that, which I believe the findings will be released a little bit further on in the legislative session, they partnered with UGA to do that. And I would like to put it on this radar because I think it would be helpful to engage, and certainly that would be a great role for the commission, is contracting with an entity, particularly UGA. It sounds like they have some expertise with this in terms of the healthcare economics piece, of looking at transportation and disposition and things like that. So, and it was not on my radar that they might be something good. I tend to look at the Mercers and the AUs that are connected to big hospitals. I don't necessarily think that it needs to be that. So I would love to maybe further that discussion at a future.
Okay. Any questions on the GTC update? Any other comments? GS mapping, education mapping. Melissa, is she online?
Melissa is online, and Katie, if you stop sharing, Melissa can share. Can you hear us, Melissa?
Yes, can you hear me?
Yes, you're looking beautiful in your remote location.
Thank you. Yes, over here. I am so sorry I couldn't make it in there. I was hoping to see a lot of you in person today. It's been a long time since I've been able to say hi to you all. But nevertheless, so I'm going to share some mapping that I did over the education courses that were taught this year, well, last year now, since we're in 2023. Give me one moment. Okay, can you see, excuse me, the PowerPoint?
Yeah.
Perfect. Okay, So year-end course review, to start, I'm just going to show you this table. I'm doing this for a couple of reasons. This was not developed by me. This was the table that I received along with several other sheets of data. But this is to remind us all, like we need the reminder, but just bear with me here, of what data looks like. So we see numbers and cells, and that's great. It tells us a good picture, but it doesn't quite show us, visualize what we're looking at. So one of the things that I do a lot is I try to add maps to my data to help visualize what exactly we're looking at. So this first slide shows the state of Georgia, and the white counties represent where a training, at least one training, occurred. So we can see what counties had trainings and which counties didn't, or which areas didn't have any trainings. And then listed over on the left-hand side are just the trainings that I looked at. Now, as a little warning, I guess, I clearly do not know what all of these trainings are. So I just put what I was given. So if there's something that's on there twice, because, I think Kathy told me that axioms of leadership and leadership was pretty similar, or something was similar. No, Arbinger was similar to the leadership. So there may be some issues with what you see in this list, because again, I'm not familiar with what all the classes do. And you can see over on the right-hand side of the map, I just put the total classes that were taught. So there were 104. We had 4,027 students enrolled, only 3,705 completed the training, and the total contact hours amongst all the training and all the students added up to 106,628. So still looking at the map of Georgia, I wanted to see which of those areas that had counties that had trainings, where did we see the most trainings happen? So this is just a heat map where we look to see which areas had the highest number. So we can visualize here, instead of just looking at the spreadsheet with all the counties listed, which areas we had the most amount of trainings in, which could be extremely beneficial if we are lopsided in one way or the other, or we want to know where we need to up our trainings, increase the amount of them. Okay, so the next series of slides that we're going to go through are maps of Georgia for each different training that I was provided data on. Now, I want to give a little bit of a warning here as well. The data that I received was zip code data. So zip code data is okay if you want to know large scale items. So if we don't want the intricacies of areas, I am a sociologist. So when I'm looking at my data, oftentimes I want to know what is going on in the area that the event occurred. So if I'm looking at crime rates, I'm going to want to know education level, income level, race, ethnicity, age, all of that. So when we're at the zip code level, all you're getting is a large area. And if you think about it, you think about how large a zip code could be, maybe the one that you live in, and you think of the clear north end of that zip code and then the far south end of that zip code. Are the areas identical? Do you go through a rural part and then maybe a couple towns, or maybe even a city? Is population expansive in one and very few in another part? Think about just the environment. Is it swamp in an area and then forest in another? So when we're looking at an area that is so large, it's really, really hard to get in-depth information. So the best way to go about mapping is to have the actual address. So the home address of the participant or the address of the training, as opposed to just the zip code. So that is my overall blanket warning. This data is just specs on the map, but I will show you what we are capable of doing at the end if we get better data. So here's the axioms of leadership. We had 3 classes. There were 29 students enrolled. 26% completed, which was a 90% completion rate, and contact hours were 520. The way I have set up the next series of maps are the dots that you see represent where the students came from. So that was their zip code of either their place of employment or their home zip code. The red county, or the counties that are shaded, is where the training, in this case, all the training was in one county, and some of them you'll see multiple counties shaded in. That's where the trainings were held. So you can see that most of the students here were in that county where the training was held. Then we have TECC, total classes were 20. You can see the different counties here where the trainings were held by looking at the shaded counties. Students, 273, only 88% completed. Contact hours were 3,824. Again, we had some clusters of where students were located, but really they're spread almost throughout the state. And we even had a couple people come over from other locations. Some up there by Chattanooga, and then a few over on the border of Alabama. And trauma skills, total class is 10. 1,040 students enrolled, 94% completion rate, 3,904 contact hours. We have a clustering of students up towards the top and then all around. There's this area right south of Augusta area, which I believe Emmanuel County, I heard you say that earlier, is in that area, where it looks like throughout all of these trainings, we did not have participants from that area or trainings located in that area. EVOC, total class is 4, students enrolled 50 or 70, 53 completed it, which is a 76% completion rate, 848 contact hours. Here we have auto extrication, 6 classes, 163 enrolled, a 98% completion rate. 160 students completed with 3,840 contact hours. Farm medic, 10 classes, 312 enrolled with only 286 completion, which is a 92% rate, 4,576. EMS, 3 total classes, 96% completion rate, 2,256. Lots of traveling for this one training, or 3 trainings. EMR, EMT, 21 classes, 434. I believe this was the lowest completion rate of 67%. Contact hours were 61,440. Trauma courses. I'm probably going to get these letters wrong, but I believe this included PHT something and ITLS, PH something. I know you all know what I'm talking about.
Melissa, you got it. Melissa, you got it. That's right. PHTLS. You were getting close enough.
Thank you. So we had 22 classes, 278 enrolled, 91% completion rate, and contact hours were 3,536. And then the ropes course, we had 2 classes, 35 students were enrolled, contact hours 512, completion rate of 91%. And then we had 2 classes that I want to spend a little bit more time on, and I'll show you why these are better to work with. So the virtual conference, this was one virtual conference, enrolled 897. There was not any notes about completion rate, how many students completed it. Maybe all of them did since it was virtual, and obviously you don't see a county because it was virtual. So you can see the map is a little zoomed out, so you can see further outside of Georgia. We did have quite a few people outside of Georgia attend. Now, it was not clear in the data whether these individuals live outside of Georgia or maybe they were just visiting and they put the zip code of where they were. I'm not really sure. That's the one problematic piece of just seeing data and not understanding the innate nature of it and how what everything means and what it's for. We'll come back to this in a minute. The second one is the leadership course. So the leadership course, we had 26 enrolled, 100% completion rate with contact hours of 4,160. Here you can see that we have two little pinpoints marked. One is an H and it's blue and it means their home location. Again, the W means work location. So again, we kind of looked at both, whereas some of the other data that was received, the zip codes were, you know, here's the zip codes and it's either where they lived or where they worked. It wasn't indicated which it came from. So the leadership course, the data that was collected asked both for a home location and a work location. So something that we could do here if we cared to do it is to see how far away the home versus work is for each student, because we have data that shows that. But I wanted to show the work home location both on this screen for you. And it appears that we did have quite a bit of traveling for this course as well. I'm going to dive more into this course first because we had the best data provided through this one. So here is just a word cloud of the titles of the students, the participants, and you can see the words that are most common by the size of them. So we had chief, captain, director, EMS personnel, coordinators, paramedics, firefighters, managers. We had a lot of overlap between chief, captain, and director and coordinator and EMS though. So that kind of just shows you who you're training. And then here we have a slide of demographics. I apologize about these colors. I changed the background because, you know, you always change presentations up until the last second. So while Liz was talking, I was changing it and then I couldn't get it back to a color that I actually liked. So here's just terrible red shades and orange shades. But gender wise, we had predominantly male at 81%, race and ethnicity predominantly white at 90%. We had age, a mean of 43 years old, the median was 47. So when we're giving age, we like to include the mean, but because we do have some outliers sometimes that kind of pull that mean up or down, we also like to include the median. So here we do see a 4-year gap. That just means, you know, if we line up every single person in age, the middle one is the median, so they're 47. But when we combine all the ages to get the average, it's 43. And then we also included data or questions about where they work, how long they've been there, and how long they've been employed in their field. So years at current position is the mean of 6.98. The median again is 4. So that means we did have a couple outliers pulling it up. The minimum amount of time spent in the current position before attending the training was half a year, and the maximum amount of time in the current position was 27 years. And when we're looking at years employed in the current field, we can see that the mean is 19.14 years and the median is 20 years. So these individuals that attended this training are well into either enjoying their work, or I'm going to say enjoying because that's a long time to stay. Or they're trapped. Is that what I'm hearing rumbling in the background? The minimum time in the current field was 4 years and the maximum was 35 years. Okay, I'm going to hit escape and bring down an Excel document for you to look at before we complete the PowerPoint. So give me one moment. Okay, so I have blocked out the names of the individuals here, but I want you to kind of see what the data looks like that I was given. So some of
Melissa,
the,
we're still seeing the PowerPoint there. I don't
Yep.
know if you have to unshare and read. There you go. That's it.
I just had to pull it down from my other desktop screen. So you can see here that this is the EMR data. And again, the names have been blocked out, but you can see that in this case, the zip code was given, state was given, city was given, The address for some were given, so not completely solid. And then the county where the training happened was given. So when I receive this, I have to do a whole bunch of data cleaning and make it so every single cell has a character in it, or the mapping software won't recognize it. And then you have to clean it up, right? So like if I have Georgia GA here and then spelled out in another area, you have to make it the same. But because there's so much missing data here in the city, I couldn't really use it. Same within the state, couldn't really use it. So even though these maps reflect students or participants, we're still missing some because these people have names but nothing associated with them. So mapping wouldn't draw them, they wouldn't grab them. So we have students that were not represented on that map. So I'm going to now go over to the leadership one. Which again, I have blocked out the names, but you can see here now the data that was requested is a lot more in depth, and you can see that most of the people filled it out. We did have 2 individuals who did not provide any of their demographics information, and then a couple individuals who didn't provide things like their work address, which is fine. We can work around it for the most part. If you don't provide demographics, then we just don't include you in that analysis, and we make a little side note that even though there were X amount of students, only this amount filled it all out. So you can see here, which class are you attending? What is your home address? Then demographics, place of employment, how many years you've worked in the field and at your current job. And then we asked for the work address. We asked for the instructor names. So this gives a more thorough picture of what, or depiction, I guess, of what these individuals who are taking this training look like and who they are and why we're training them. And this could become very beneficial if you need to know what group you're missing. Is there a certain subset of people that you're missing, or a certain location, people from a location you're missing? It provides us with the option to do further analyses to, again, get those demographics or get that employment information or whatever else you seek to know. If it's filled out properly and appropriately, we can include it in analyses. So I'm going to close this out and go back to the PowerPoint. Okay. So I pulled maps from several different projects that I have been on, just to kind of give an indication of other things that we could potentially do if we had the correct amount of data, or the data, if we had the correct questions to get the data that would let us analyze what it is that wants to be known. So here, some of you will probably recognize some of these maps. I did try to drop some of the data, so they're not 100% recognizable. But if you were on a project with me, which some of you in the room have been, you probably know what they are. So we could do a travel time. This is what this is. We're looking at the travel time to certain locations, and each color represents a different block of time. So the idea here is to see how quickly individuals living within a certain color block could get to a needed location. You can look at distance, so you can measure it. You can add in different types of elements. You could say, in a rainstorm or during rush hour of Atlanta, how long would it take a person to get from A to B? Again, I'm going to tell you things we could do. I don't know what is 100% relevant for the trainings you offer, but if you want to apply trainings and maybe look at, what kind of event or incident or trauma we're experiencing in an area, and we want to increase the trainings for that, we can kind of overlay it on maps and look at it in a visual regard. And then we can also capture areas, so we can see how many people live in this area, or how many people live here but work outside of this area, or how many people in a certain field are traveling to different trainings. So you can do a capture of areas. We can also do a hotspot or density map. I showed you a hotspot map at the very beginning. I'm going to show you another one here in a few minutes, but this is a density map. Kind of looks like a tornado, and it is oftentimes used for weather events. Here, this was not a weather event, but it is showing you over in my area by Augusta, where something is more likely to happen. And the darker the shade, the more of those events happen in an amount of time. So, you know, I think it was all of 2021 that I mapped here. So in 2021, we had a lot of stuff happen in that dark area, and then it kind of what the lighter areas is where we saw less. So applying this, it is a medical scenario. So now we know that in that area, we need to focus some of our training and personnel. This is just another hotspot analysis where we then captured some information about the area. So as I told you, being a sociologist, I'm really concerned with what the area looks like and how that correlates to the event that we're researching. So here we located hotspots for a crime, and then we zoomed in to each hotspot and highlighted that area so we could kind of see the makeup. Using raster data, we could kind of see the makeup of the environment, because we do know, as criminologists, we know that certain areas lend themselves to more crime. So then we also put down just census information about this area so that we could compare and contrast. We could also overlay with other data. So here is looking at the survival rate, which again, I took the data off so you can't see the rates. And it is paired over, can't really remember what it's paired over. Might be education level on this map. And we just, again, with the study, it called for census data and it to be under our, did they survive or not survive? So we can capture it that way. We can also see change over time. So Maps offers literally almost like a movie where you can start it and you can see the changes. So Liz and I oftentimes talk and have worked together, and there's been a lot of conversations about mapping the changes of trauma level hospitals. And we know that they change. We know that some have bumped up and some have gone down, and some have disappeared and some have come on. We could actually put together like a movie to show the change over the past 10 years. And then before and afters. So you can make this slider, which you see on the right, which this is a still image, so you can't actually see it slide, but that little arrow thing, I can slide it to the left and right and show before or after. In this case, it's not before or after, it's child murder and child abuse rates. But we can also put rural counties on, which when I did this map a couple years ago, the purple represented the rural areas. So we were looking at child abuse and child murder, which is my area of expertise, the prevention of those two, over the whole state of Georgia, and the rate and the change over time. So we could see if murder in rural areas was just a rare phenomenon, or if it correlated to child abuse, and it did here. So there's a lot of different things that we can do. I'm going to escape one more time to show you one more thing. So these are the story maps. Somebody please let me know that you can see child murder in Georgia across the screen.
Yep.
Perfect. So this is just what I was saying, where you can kind of go and see before and afters. I'm just going to take you to the quick slider so that we can do before, and then this is just adding virality to it, so showing the difference between, but that allows you to kind of do the sliding. And then this function stopped working, but I'm going to show it to you anyhow, so we can see the whole state of Georgia. And then Calhoun County had was one of the top 5 counties of child murder when I was looking at it. So it zooms in and it's supposed to highlight the county, but that has stopped working. I probably need to go and do something with a plugin. But so there's a lot of different things we can do with mapping to better your understanding of the educational training and where our needs are, and what we could do to better the trainings or the increase the amount of people who come. So then my last slide is just, do you have any questions?
Melissa, this is Kim Littleton with Georgia EMS Association. Can you hear me?
I can.
Courtney, I can address some of this in our report or address some of it now if you want me to. Either way, I just wanted to make sure that I clarified a few things that Melissa had on some of her data.
Well, go ahead and ask if you like.
Yeah, Melissa, I don't think you and I have had a chance to really talk about some of this, and I know that it'll probably clarify a few things and some of the rationale and reasoning behind why some of the mapping looks the way it does. We have new data, I think, that's been provided on some of this. It may not have all been incorporated into this report, but there are a couple of things that when we go back to some of the specific classes that I want everybody to consider. On the leadership program, I know the distances that you're showing on there and how far people travel for that. I think one of the things that you may not have been given information on is that several of those locations for the 4 modules of that class are contractually set because of our partnership with Georgia Southern University. So that influences a lot of that. And also the other 2 locations, they're usually set, a year in advance of going back to repeat locations like we were in Gainesville for a while, we're in Rome for a while, we're in Pine Mountain. So some of those are set that's just the locations for those 4 modules. And like some of the other training that we do, those are the locations that have the capability for putting on that training. Cadaver labs, the EVOC class, Axioms specifically, some of those trainings, we have to have certain parameters, certain criteria to even be able to conduct the classes there. So we can certainly look at other areas and how we develop different training sites, but some of that is out of our control as far as the locations for those classes. Also on some of the trauma courses. Those trauma courses are, of course, applied for by the counties, by the services. And then some of the ones that we're involved in, well, all of them, if they're an NAMT course, which is the PHTLS, ITLS, AMLS, so all of those courses that fall under NAMT, they actually have to have established training sites. Not every service or every location has an established training site. So if they are not already established with NAMT to be able to conduct those courses, then affiliate faculty, me or others that are affiliate faculty, have to go in and do checkoffs for that. So in some of those areas, that's why you don't see a lot of courses going on in certain areas. They don't currently have those training center capabilities. Also, on one of the courses, I think for TECC, you saw that there was a lot of not a lot going on in the Middle Georgia area as far as the ones, I guess, the information that we gave. The Middle Georgia TECC classes have primarily been conducted out of the RTAC in Region 5. So where we have established areas where they already are doing those type courses, my vetted instructors and that program that we oversee from the association, we try to let them do that, and we provide support to them where needed, but we don't go in and conduct those courses. So that might be where some of that gap is coming in that Middle Georgia area. Also, with courses like Axioms of Leadership, those have been also established locations where we've had that course in the past. There are some things as far as the obstacle courses and things that are required for that we can't just take those into every area.
Thank you, Kim. I didn't mean to say anything negative. I was just impressed that there was so much travel.
No. And I didn't mean to come across that way at all. That's not what I mean. I wanted to, because I know that you and I had not had a chance to really talk about it, and I wanted to provide some clarification because I knew that there were some more information that we need to give you, and we haven't done that.
Yeah.
And we certainly want to be able to do that. So nothing negative at all. I just did want to provide clarification on it.
Perfect. Well, I appreciate it because that does make a lot of sense. If you have particular things that need to be done, you have to have facilities that allow for them.
Courtney, can I ask a question?
Sure.
So good information. Thanks for showing it. It's impressive. Is it possible, and Richard and Kelly, I'm looking at y'all for this too. Is it possible to take last year, 2022 and going forward, information from the state office, along with the data you've got here on initial education classes that are taught, and plot those by class, meaning EMTR, EMT, AEMT, and paramedic, with the same general information that you're getting, number that initiated in the class and number that completed. It'd be great to be able to put number that got a national registry and state number.
We showed that in August 22 at the board meeting in May.
But where it's all fractured. It's not include, is it including this data too?
Of CE courses?
Yeah. Is it including,
It was additional education only, like you just asked for, EMR, EC, and A.
okay, so is it got the same, I remember the bigger pictures, you know what I'm saying? But did it have, it had every class y'all approved,
Yes.
period? Okay, so is that data able to be broken down the same way this is?
Maybe I don't understand you because we did. So if you remember, we broke it down by,
The problem is I don't remember,
okay.
to be honest with you. That's the real problem.
So we basically showed a heat map of where all the.
Okay.
Well, first, where all the programs were in the state.
Okay.
Including satellite. But where a program was at, then we showed where, how many EMR courses were held from state, how many students were in those courses, where those courses were held at, and where the students came from by zip code.
Okay,
We did that for all 4 levels of initial education.
okay, and do y'all maintain that database? I know you maintain the information, but do you maintain the ability to map it the way you did then?
Yeah, I mean, we could, it took Ryan, what, 2 hours to do something
Okay.
like that, but yeah, it's all there. It's just gotta be pulled up.
Because I think as we all talk about workforce, because you see the convergence from multiple reports from different agencies and looking at them and the governor's task force, workforce is at the top. You know what I'm saying? And so these maps, I think it's impressive. I'm glad we're able to, the Trauma Commission willingly funds all the LS, and I use that term very generally, but the extrication, the farm extrication, I'm glad they do that. But if we don't have medics, and I use that term across all spectrum, if we don't have them in the streets, we can't respond to calls. So it goes back to workforce. So to me, I think this information is great. I love it. I'd love to see where we're funding classes, initial education, which I guess we're doing EMTR and EMT are the ones we're doing now. Is that not right? And then I'd like to see how it's overlaying with what's going on in the state, because there may be pockets that we need to be reaching out to and saying, hey, there were clear pockets when you looked at this for different types of education.
Well, we're funding every class except for a paramedic program. We're doing EMR all the way up to advanced.
I know, but are we doing, do you know how many we did last year?
We just passed the advanced.
Slide in there.
And I'll also comment that the enrollment rate and essentially the retention rate, that's pretty high. 67% what it showed was the number that from 67% of those that enrolled in your EMR and EMT classes completed them. That's pretty.
Does completed mean they became Georgia
No,
licensed?
they completed.
Yeah.
So
To me, that's the final piece we need.
Sure.
The completion or the became
I
agree.
And then the next one would be great. Are they working in EMS?
Well, yeah,
Because if they went to a hospital.
they don't know the same.
well, at the end of the day, if they went to the hospital, that's not an education problem.
I'm not arguing that.
That's our problem.
Yeah, I'm not arguing that.
So I think but I will say this, that one of the recommendations from the governor's task force is that the state develop a database of all the training and all the completion and success rates of the training for all of the disciplines, including EMS, and that be on some kind of a centralized database.
And I recognize every county can't have an EMT class. That's not practical. And again, I'm using EMT across all spectrum. But at least regionally, there would be educational opportunities regionally. However, regionally is defined. I'm not necessarily saying 10 regions, but they're natural regions through the tech schools and other things that don't necessarily overlay every other region, basically.
I can't remember if we recorded that consortium meeting and making it or not. If I did, we'll share it. We can definitely share the slides with everyone that shows that.
And I think y'all shared them maybe here before. I have a vague memory of seeing them, but I think that information will be good as not necessarily every meeting, but a quarterly meeting or something like that, just so we can see.
Maybe something MSAC, you ought to put on a standing thing.
So do we want to include that for the next meeting?
Well, it sounds like
Yeah.
it's already there. Maybe we just need I need a refresh. I don't know if everybody else wants. I need a refresh on what Richard and them have.
Maybe Richard could just send it out to the, we could just send it to the group by email and see.
I think that'd be great. And Richard, well, that was 2021 data shown in 2022. Is that what it was roughly?
We may just repeat it.
That'd be great.
Our old stuff, we may just repeat it, because that was August, and so we've had a lot happen since August, including some we're improving from COVID, like our numbers are getting a lot better.
Yours might be, but ours are.
Well,
You see-
I'm saying nationally speaking, like we had a
Delays with what
huge
they
drop
have.
off
That'd be good.
in national registry data, but
You think?
Well, I think, some of our previous meetings, that's what I was talking about, needing to have at least one class in every region every year. And it doesn't matter who does it. If-
Well, that's only 10
If there's a
classes.
technical school doing it, that's great, but if we have areas where classes are not being taught, that's where we need to focus on putting classes.
we definitely have that, like there is at least one of each taught in each region. Well, with a little bit of clarification there, sometimes the paramedic class, like take region 6, a paramedic class may be longer than 12 months. So like you could have 1 year represented where they started in that year, but didn't finish in that year, so it would appear, but generally speaking, we have hundreds of EMT classes around the state.
But even in Region 6, the paramedic class is taught by AU.
Right.
So if you take that paramedic class, you write a check for the full meal deal. There's no Hope grant, it's just the way it
So
is.
I thought EMS was a couple of years ago listed by the governor as a, what do you call it? critical-
It is, and that applies to the technical colleges, not university.
University they can't get Hope grant. There's a Hope grant, Hope scholarship. If it was within their regular curriculum, they get scholarship money for it, but it's
So
not.
maybe that's something we need to add to the budget list of what we need to address. Why is it not?
Well, I think one of the things that came out of the governor's workforce thing is that they need some kind of consistency, and I'm not trying to make enemies, but when the technical college presented, Dr. Worley from Augusta Tech presented a wonderful, and it looked like he developed it for the local exchange club about what all they were doing to work with Piedmont. And it was really a great thing. They were using one of the old hospitals to do training on this. Not one word about what was going on statewide with EMS training in the technical college system. So I never really did get over my frustration with that. So, but that is a huge concern to me that we as an industry are funding. Go to the hospital and say, what would happen tomorrow if you had to start training your own nurses? They'd have 2 seizures in a dove.
They used to do it.
Yeah,
They got
yeah,
away from it.
but only like Atlanta Medical or back Grady, George Baptist. But that was 40 years ago, wasn't it?
Are you saying I'm old?
No, I'm saying I remember it very well too.
So it sounds like Melissa's data that she reported for the EMT and EMTRs, it was listed, if I remember correctly, is a subset of Richard and the state's data, because it's only looking at classes that were funded through the trauma commission.
This only.
That's it.
Right.
This is.
But if-
She just sends over the
Right,
spreadsheet.
right. So if Richard can get his data refreshed, that'll give us statewide data for everything.
Yeah, so then, that's a great, Richard, let's get together offline and let's talk about a way to show that, so.
Because that would be the ultimate goal, is to see it in everything, not just the trauma commission funded classes.
And that is exactly what the healthcare workforce's issue is. They want to see that for every profession where they're coming from. I was amazed, nursing pass rate's great, but the completion rate is 27.3% on RN and LPN. So if you start the program, only 27.3% completed. And so we have one issue, pass rates, which according to McKinsey Group we're just above the 25% worst, at the low 25% pass rate across the nation. So we suck. That's probably not a good term to use on the TV here, but we need to improve that. And I'd love to point too many fingers, but at Emmanuel, we brought that down last year. So terrible. Anyway, any other questions of Melissa?
Good work.
Dr. B. Miller, thank you so much for that. That's good data, and we appreciate all the work.
And it will get better because now Kathy has access to that street level data that we couldn't create a lot more of those more dimensional, maps that I think would really tell the story. So Melissa's excited to work with that data.
Yes.
Thanks, Melissa.
No problem. Thank you.
So Tim, you're up.
Actually, I asked him if I could go next because we got to get to Columbus for trauma skills lab.
I'm sorry.
I asked him if we could go next because we've got to get to Columbus for a trauma skills lab.
Okay.
Thank you.
I'll just drive back.
So I can support this.
That's actual funding source.
Well, dressed, look good, sharp, nice. I told him, thank you for serving the community.
Some people drive the speed limit.
Yeah, and believe me, when Keith was working, they called him Mr. Magoo. If y'all remember Mr. Magoo, never had an accident in the fire truck ever in his 35-year career. He made it to the scene okay, but Mr. Magoo. So we don't drive over the speed limit. So, Melissa, if you're still listening, thanks. I appreciate that. Just on EMR data, a little bit, some things are a little bit skewed. It didn't look like there was anything going on with the north end of the county, but Metro, Rob always lists Cobb County as a training facility. So even though there was like last year, I think there was a grant for Bartow and Dave up in that area that it's not reflecting on that county.
Probably Pauline.
Pauling, yeah, because he'll list the Cobb County as a training facility. So, well, I'll get with Melissa and we'll work in detail that a little bit better. Again, I want to thank the Trauma Commission for our partnership. I've got some awesome training that's going on. We are tickled to death. A lot of good feedback, and I can provide all of that because we're doing surveys on the classes now. It's good stuff. This is just our quick report of where we are right now. Start out with the trauma skills lab. We've conducted 3 so far. We are headed to Muskogee County today to meet with Mary, and the lab starts tomorrow with 165 people registered. It's good stuff. We've got good turnout. People are loving it. We're able to provide with the paramedic classes. They're coming in, they're getting all of their skills. If I can, I want to share a really quick story. Last year, we had Georgia Piedmont bring their paramedic classes in. Guys, they can do as much as they want to and just try and as much as they can. One guy was practicing his tension pneumothorax relief. Did great, went on his third, he was riding third. Got a gunshot wound. Paramedic said, "Hey, what you think wrong with the patient?" He said, "I think he's got a tension." Absolutely. What you think you need to be done? I think we need to relieve that tension. Paramedic said, have you ever seen it done? He said, "Well, I've actually done it 5 times at one of the trauma skills labs." And he said, "Well, you've done it 3 more times than me. Let's go for it." He let that student decompress that chest and save that kid's life. 20-year-old, good stuff. And he said he never would have had the confidence to do it if he hadn't have come to the lab, which is just chilling for me. It's good stuff. So we've got all of those set. And this next section is the gray bars are the people who declined the grants after accepting them, signed all the contracts, which I make companies sign them, initial them so they know every step of expectations of us and what we expect from them. The pink is services that I'm herding cats on. So we'll move on that. Real quick, y'all gave us the funding for 51 classes. I gave out 67 grants. All right. So some of these have since replied to me. You can see that I either email them or call them and put a read receipt. And a lot of these people since yesterday, I was spent all day yesterday updating this spreadsheet. But we've got all of these classes going. If you'll move to the next slide, it's all listed alphabetically. The next ones. I try to list when the date they declined, so I'll know how much money was held up.
Are they giving you a reason why they're declining?
No, some of them say, well, you know, we only got 3 people to come to class and our minimum is 12. You must start out with 12 students. I don't see the need to spend the money if we don't. So.
Courtney, I'd like to, Kathy, if I can interject something here right now, it's kind of some of the same situation that we run into with some of these courses, even the ones that are held, and I hate to say this because I'm down here, but that a lot of them that are held in South Georgia, where we don't have the attendance to those courses like we do in North Georgia. It's very easy for us to take a class to Rome or to some of these other areas up in North Georgia, because we know that every time we conduct a course up there, it's going to be filled. We do not have that in South Georgia.
The next slide, EMS instructor preparedness. We're doing a little bit different. We have been conducting the class at Gypstick, which was comfortable to everybody, but this time we're going to move one to Morgan County up here at Hard Labor Creek, coming up pretty quickly, and then one in Doherty County down in Albany. See what we've got, and both of those classes are full. They filled up quickly. Axioms classes, got 2 of them coming up. I don't know if any of y'all knew Mo Baxter, Chief Baxter. He was our lead instructor, recently passed of cancer. It's a great loss to a lot of us. Some of the people that were under his tutelage have stepped up and have agreed to step in and do some of the lectures. So we're real excited to see what they're going to produce. So we are going forward with the Axioms of Leadership classes. So got 2 coming up. The NAENT courses that we talked about. Again, the gray represents people that have decided not to do these classes. But again, knowing this is, some of this happens, and I know it's going to happen. That's why when y'all gave us money for 51 ENT classes, I gave out 67 grants. So in knowing that, we've approved, these are our NAENT courses. Rick Ellis down there, we gave him the money for a PHTLS, and he called and he said, if I have the same budget, can I do a TECC class? So I said, Kim and I said, sure. Again, they're funding Region 5, and they needed that in that particular class. So that occurred, did a good job. Next slide. Total of 29 of those classes are happening. The TECC classes, these are all that are on the books. Again, great reviews. And again, this is a particular class. It has to go in particular areas because NAENT has to approve the site for this class to happen. So that's why you'll see us going back to some of the same places, unfortunately. Deals with the surroundings and the equipment that particular place has. Next slide, please. Farm medic, this is what we've got planned. We have a few more to get planned on the books, but this is what's happening. Great reviews out of that. Super instructors. Take a look at that class. Next one. The auto extrication with patient care focus. Got 1 more of those to get on the books, but that is a fantastic class. We're well supported by Hearst, Hamatro, Paratech. Who else gave?
All your major.
Yeah, all the major equipment. And with these classes, we are putting mannequins inside of the cars, and the guys are having to treat the patients at the same time that they're bringing them out of the cars. So it's a full gamut of get on the scene. This is what we've got. Because in most of your old EMT class, or your extrication classes, I don't know how many of y'all done that, but how many of y'all stood on the driver's seat cutting stuff? I'm like, y'all can't stand there. There's a patient there. Think in your head. So with this actually happening, and there is a patient there, and somebody in the back trying to take care and cover the patient up, it's good stuff. Good stuff. Next slide, please. The leadership program, we're in the process of accepting applications for this year. Kim will make the decision with a group of people, the alumni, and we'll come up with another 27 to 30 students for this coming year.
Kathy, just a note on that too, January 31st deadline on those applications, and I've already received 35 applications for this year's class.
Awesome. Good stuff. Next one. And again, we're planning to, we're continuing to meet the educational needs of what is in the contract and do our best to be as fair giving this out. Okay. One more thing that I need y'all's help with. Region 6, the Trauma Skills Lab is scheduled for February 20th. I've talked with Ryan, I've talked with Richard, I've talked with Gina. They're going to try to push it out, get it to more people to notice, but right now I have 33 people signed up for that lab for February 20th. I've tried reaching out before and pushing.
I haven't seen that amount.
You hadn't seen it?
I haven't seen it.
Okay, I'll send it back out again to, because I know I asked it, send it to the RTACs, the regional training people, the region directors, and said, please share this with all of your directors. Maybe because Nikki, okay, but yeah. It probably went to Nikki. So just trying to, they said they would do a big push again, but whether it's your money or my money, I'm tight. Keith will tell you, if I open my wallet, George Washington squints because he ain't seen the sunlight in so long. We got married. I said, don't ever bring me flowers. I want stocks and bonds. So I appreciate your money as much as I appreciate mine. And I want to get the biggest bang for our buck. To me, we've got to get more than 33 people signed up for that lab to make it worth the buck.
What's the minimum?
It hurts my heart if we walk in there less than 80 or 90 signed up, because that's a lot of money.
A lot of money for,
Actual
yeah.
location, is that one down in, near Statesboro, Swainsboro, or?
No, that one's,
Region 6, where that?
Region 6 is going to be at, it's Liberty Gym. It's in Martinez. It's really easy. Yeah, it's Augusta, and we offer nursing credits. We offer state office of EMS credits.
There's something going on.
Yeah, if y'all know anyway, I resent the flyer to Gina and to Richard and to Ryan and Regina Mendoza. I asked her, I said, please get this out to folks so they can come and join us. It's phenomenal stuff. But if we can't get close to 80 or 90 signed up, are y'all in agreement that that one needs to be canceled and we need to think about somewhere else to put it?
Yeah.
Because that's a chunk of change. It's like we're going to Columbus, and I had people emailing me last night going, hey, you still got more? And I try not to turn anybody away. I gave them a time and said, y'all show up, we'll fit you somewhere.
So how many will you have in Columbus roughly, based on sign up?
Right now I got 165.
Yeah, there's a big difference between that.
Yeah, there's something
Yeah.
amiss.
Do that.
I won't spend your money as well as I spend mine.
And another thing I wanted to add to that too, we've had some challenges with some of with especially one of the cadaver classes that we were trying to do in Region 3. And I actually am going to the Region 3 council meeting coming up too, because we want to make sure that we're getting as much information out as we possibly can. But like I said, there are very specific criteria that we have to have for those labs, and some of the communities that we've tried to go into where we would love to put them there, they just can't secure the facility or can't guarantee the arrangements for us to be able to do that. So we're doing everything that we can to try to make those other locations work, but sometimes just logistically it will not work.
The one big thing is you want it cold. Cadavers and warm is not quite a bed of roses. Y'all know what I mean? So that's just a facility big enough, keep it cold enough that they can handle us in the field, let us bring cadavers in.
Okay, any questions? Other comments?
Courtney, I wanted to add a couple of things that Kathy didn't have on her list. If you'll give me just a second. We just submitted our fiscal year 2023 Q2 invoice, so we should be up to date on our invoicing to the Trauma Commission for everything. Also, we're at this midpoint. We're doing our midpoint soft supply order. So a lot of our supply budget will be getting up to speed on getting some things ordered. A lot of the equipment that we have that's purchased from either TCC or the cadaver labs or some of those things that we maintain the equipment for, they get a lot of wear and tear. So we have to go through usually at a midpoint and try to refresh that equipment or make sure that we're staying up to date with everything. Also, one other item that I wanted to mention, although it does not have anything to do with Trauma Commission funding, but we've been working on this and it does impact all of us. I want to make sure that y'all are aware of it. We don't have the funding yet. We have the initiative came forth from a couple of members of the legislature, but we are working on what I'm referring to as a capital response team that will be made up of a paramedic and an EMT that will actually be staffing the Capitol during session. We are shooting for a date of January 31st to have them in the Capitol, but it's required some logistics with Grady. We've also had conversations with Metro Atlanta. Pete has provided a lot of information to us. Also, Clayton County has assisted us with helping get some things pulled together for that. But we hope to use this as an opportunity, not only to help people, the legislature and visitors to the Capitol during the chaos that goes on during 40 days of session, but also to bring more visibility to the association, to trauma care, to all of our partnerships and us working together to try to get things done and try to protect people and keep people safe and assist where we can. So I did want to bring that up as another item that we're working on, that you'll possibly see those people in the Capitol if we can get everything pulled together later on this month.
Thank you, Kim. Any other questions or comments? Mr. Boone, Dr. Boone, excuse me.
So as we get started with this, with the automatic, with the ABLS system, we've got, we're looking at a lot of data out there. And in looking at the data that we just looked at and training and the whole workforce thing, one of the issues is we can actually see, and each one of you in your agencies can see right now, where ambulances go, when they stop, how long they stop, where they go next, etc. 24/7. We could, if we had the legal authority to do it, permission to do it, use that data, collect all of that, and it will produce, even in the current AMN, hotspot maps and so on, and tied in with this other data could tell us a lot about, okay, so you need a workforce. What do you need a workforce for? Well, we got ambulances going here, here, and here, but we don't have any going here, here, and here. And how does that relate to where the training is going on and so on and so forth? So there's a lot we could yet do there. There's opportunities, I think, to take a look at. The critical thing we've got to do is get immunity from the data from the state somehow or another, so that it can't be used against anybody. We haven't had any of that problem. In fact, people have used the data for positive purposes, but helpful purposes, both in terms of fleet operation and also in terms of a couple of legal situations that have come up over the last couple of years. The other thing is, Sierra Wireless has been acquired. They're no longer a standalone company. They've been acquired by a company called Syntec. Syntec is a manufacturer of a chip, tracking chip, and a thing called LoRa, which is a low power, wide area network situation that basically works when cellular goes down. This thing still works, and the chips still talk to each other or connect with each other all over the place. The cost of a chip is about $20, as opposed to the current asset tracking that we have through Sierra Wireless, which is $100 or more per chip, which means that you can put a chip as this integration takes place. Those chips would be available. You can put them on just about whatever you want to spend $20 on and track that asset wherever it may go. The other thing you might want to think about, just in as I was looking at this and going through with what they're doing, is the possibility that that's a way to track patients all the way through care, from the side of the road through that first stop at that hospital, through on to wherever they go, in the case may be. If that chip were simply in a wristband or something that were placed on that trip. So it may make that whole notion of patient tracking much more realistic again. In the past, it worked so very well, but now it probably could. Well, those things are coming out. And that leads to the next little bit of news about it, and that is that the new technology is out there to replace the gateways that we currently have, the MG90s. We started out with OMG 2000s, and now we've gone to MG90s, and now there's a replacement for the MG90 new system with a whole new kind of website goes with it. That will be that's already being sold. It's being used in the field. It's got a year's worth of track record out in the field. But we need to consider the idea of when we want to start phasing that in and replacing MG90s. They go out with this new XR technology. The roadblock has always been, just like with anything else, we have this website called the EMM where we track everything and see what's going on. And the new gateways don't work on the AM. They work on a different system, better system, right? However, they listened to us when we said, hey, we can't just turn over the state of Georgia ambulance fleet overnight. Physically or financially, we can't do that. And we can't go without being able to see the ambulances and so on. So they've come up with a way to have both the current AMM. So if we have ambulances that have MG90s used and companies using the AMM, we can also have some ambulances with the new XR technology, and they're building a place in the web where all the mapping data will be combined. And so the feed that goes to your CAD or dispatch, or wherever the data comes back to for mapping on your computer, you'll be able to see everything. You'll be able to see everything, even during this transition. So they really are paying attention to the use case that we have out here in doing that. So that's just a sort of prelude of coming attractions, things that we're going to need to make some decisions about as we go forward. We don't have to make any of those decisions today or whatever. But
So let me ask you a question about that. So we had the agreement with GEMA and the state office that in a disaster, they could track our trucks to help manage like evacuation from the coast.
Right.
How does this new platforms impact that?
no problem. That's the whole idea. That when they tie they'll pull data from the AMM and data from the new system, put it together with the GPS data, and it comes available to the AMM and or into I forget the name of the system they use in the State Operations Center, but also into CAD systems. So,
Tim, does that tracking chip you're talking about, does it work on the older models and the newer models, or is it just on the newer models?
It'll be just on the, well, likely it'll be just the newer models, because it's not quite doing it yet, but it will be this summer available and doing that sort of thing.
Does that chip also do temperature?
Yes, it does.
Is that a monthly fee or one-time fee?
Oh, that's the next question I was gonna ask. So if you buy 20 of the chips and put them on 20 pieces of equipment,
Yep.
you don't pay a monthly charge on top of that?
Right, but currently, what you're talking to me about the one-time.
Right now, they're still in the beta.
Yeah. Well,
They realize $20 is too cheap and they need a reoccurring.
and here's the thing, we're already paying an annual.
Well, they figure that's
fee
going
for
in
that
the
annual
ambulance,
maintenance.
it's not going in a UPS truck.
So we're paying for it, one way or the other, but it's not an additional.
But I have to promise,
Yeah,
$20 is doable.
so it'll be interesting, and of course, it's new management, all of the senior management of Sierra Wireless is gone. The senior management of Semtech has taken over. The field and technical and operational sides of things haven't changed. And because the companies sort of have their own specific manufacturing, their own technology and all that sort of thing, and they bring it together to go in the field, and they've been doing that with this new for the last few years, which is why Semtech decided to buy them. Because they've been working together and putting their technology in. But so far, our sales reps and that sort of thing are all the same, so no change. Okay. So support deliverables, nothing of any great excitement in here. It's just ABLS troubleshooting as usual. A lot of focus on ordering units for people during this period of time because it got, interestingly enough, new ambulances. There's a bunch of new ambulances that have come in the last few months. And so we've been ordering equipment and dealing with that and also getting SIM straightened out. We put in place the window of opportunity for changing carriers. And that's in place. And we've had a couple of agencies that have come in with requests to change carriers coming fiscal year, but that's all so far. And that period closes fairly soon. That window closes fairly soon. But that's what's the kind of thing that's going on there. There has one thing I'll share with you is a lot of the agencies have become more used to and more sophisticated in getting support from ITS, our supplier, and Sierra Wireless. So that's good news. That means that more units are getting fixed quicker and staying online and that sort of thing. Okay, next slide. Total unit usage is no big change. It's about the same as it was last quarter. 1,196 units that are active out of a total of 1,415 that are out there, 85% utilization, which is pretty good. Some areas are higher and some are lower this time, and some of that as a function of new units being added that haven't quite come online yet, and a number of changes like that. But it's staying about the same as what it's been. Okay. Counties without ABLS. Well, Cherokee County, interestingly enough, I got a phone call from Jason Blevins the other day, and Cherokee is very interested in the new in the Sierra Wireless technology and being part of our system. So we've sent them some information. There's some conversation. We'll have some more conversation with them this week based on this new change that just happened with Sierra Wireless and the new technology. But that would add Cherokee to us. Camden, still in discussion. Parson talking with his county. Chattahoochee, Muskogee, not likely right now that we're going to pick them up because they have other systems and we cannot. Still waiting for a meeting with AMR and CAP Fire together to talk about where we go with this. It's just getting it to be the priority. In Long County, I still haven't been able to talk to Dr. Graham and out of the state doing other things. And Lumpkin, of course, who said purchased their Cradle Point system from FirstNet. So that's where we stand. Those are the areas where we've got holes at the moment. Okay, no change in our quick reference guide. Now, our airtime, this is just basically saying who we're paying what for airtime that the Trauma Commission is providing to the agencies out there. 1,253 of the 1,415 agencies are being paid for by the Trauma Commission for their airtime. And you can see it's split around the 4 agencies. Actually, Southern Link had been pretty rapidly picking up, and in fact, the new changes that we are seeing for this next fiscal year in both cases are going to Southern. Okay. CHI Hospital at Fort Oglethorpe has come online, and they've taken over 911 responsibility for Dade and Walker County. And they've gotten a bunch of units and they're getting them installed right now. And so they'll be running at least 10 units up in that area. And then you see, I've done something here a little different on the purchasing. I actually put the detail in so you can see of our budget of 134,000 for this fiscal year, we spent 101,000 as at the end of last quarter. And you can see specifically what we spent it on in terms of the gateways and the annual support and dome antennas and paddle antennas, etc. If you could raise that up, just slide just up a little bit and see the total of the bottom.
Then what's the new device called?
It's an XR technology. I can't remember XR 15 or XR.
And what's the cost of it?
They're a little bit more expensive than the MG90s, but I don't know we don't have a final price yet. But not a whole lot. Basically, it's the same price point.
And it requires the same kind of antenna configuration?
Yes. I'll be getting a lot more information on it and I'll bring that and probably, if you like, what we can do is set up and have Sierra Wireless come in to one of these meetings and actually some other meeting we set up online for everybody and do a deep dive presentation through all the applications of how to use what can be done and how to use the new system.
As much business as we do with them, it's probably a good idea to see if they would send a rep.
To do it?
To send a rep to one of our meetings.
Yeah.
To just discuss what their plans are and what we can expect and.
They're happy to do that. Dan Sullivan, who's the national sales manager, lives in Jacksonville. And he comes up here all the time and he's more than willing to come to the meeting. And he's a good representative, good person to have that
Do you want him to
conversation.
come to the April meeting?
Yeah, I think it'd be good just to,
Can
as
you
much
connect
money as we spend.
Gabby and myself and him by email?
Yeah.
Get an invite, make sure.
Okay. And I'm not going to go through this, but you can see it's the same 1,415 and the online 1192. And then this is for your information. It gives you the breakdown by agency. You can see what units are there. Oh, by the way, one of the things we have done, I sent out a request to get these state vehicle ID numbers put on the AMM, and people are starting to do that. We haven't got them all in there yet. But they're in the process, and I keep seeing them changing and being added. So that is going into effect. There's 34 pages of that, so we probably want to.
There's something agencies to do is at their.
Each agency can go in and put their numbers right in the name. If they've got any questions, they can just call me. I'll be happy to walk them through how to do it. It's a good way. Some agencies really use the AMM and look at their vehicles and track and use it. And some agencies don't. All they use the ABLS for is a Wi-Fi hotspot. Getting them to actually get online and see what's there and see what value they can get out of it is like sometimes light bulbs go off. So any time I can get somebody on the phone and say, okay, here's the log in here, let's go and I'll do this with you, show you how to do this. Then that gives me the opportunity to show them some other things and hopefully get more use out of it. So okay. I have then sending communication through the RTACs and through the regional directors to get out to people. And that seems to be working pretty effectively, getting the word out. All right, thank you.
Any questions to Tim? Okay, EMS funding, the only thing I've got on that is being worked on as we speak. We do now pretty much have the super speeder and a fireworks money that automatically comes to us thanks to the bill that passed year before last, I think. So that money that's dedicated to the trauma commission will go there. The big thing that's changed is that in years past, sometime in March or April, we'd be looking at amended money. And I'm not saying there won't be any, but I'm not thinking there's gonna be a whole lot. Unless somebody at the legislature puts a bunch of money in for us, I don't think we're gonna see a whole lot of amended money. So what we're going to be doing, Trauma Commission, the EMS subcommittee, everybody, is that full year budget. We'll be doing all of our work through that. Does that make sense? Okay. Any other questions about any of that? Old business, I think we talked about the equipment grant with a little bit. Was there any request for special allocations? There were? Okay. All right, good deal.
Here comes special equipment request lady.
The first one is Hall County Fire. They actually are asking for a deadline extension due to limited Board of Commission meetings and work sessions. He called and he said they used to have the chief sign off on the grants, but they now have a new grant lady and she wants to go through a different process. So they have to go before the Board of Commission to get that voted or signed off on. So he's asked for a 2/13 deadline.
What is our current deadline?
March or February 1st.
So will that cause you any grief?
No, not for.
So I don't do a lot of business when it comes to county budgets. Why would that not be something we would have already known ahead of time?
Why would,
I mean, I know county commissions meet monthly and they have work sessions monthly, so I'm just asking. I'm not
Well, I
sarcastic,
can-
I just.
To help you out with our county, we almost dealt with the same issue because there's some people that come in and handle the grants, they handle things different than maybe the other people did. The way we got around it is that we went ahead and submitted our application.
Right.
And we're gonna go to the board when we get the receive the amount, to get it to approve us receiving an amount. That's why we're working on it, just because there was some differences with our staff.
I know they meet monthly,
Yeah.
year round.
Right.
So what?
Monthly, but then you gotta get on the agenda. If you're not on the agenda at a certain time, then you can't do it.
Yes, it's a 6-month process.
So I'm assuming that's
point in time.
I just don't want to open Pandora's box when we do this, and I'm not opposed to doing it. I'm not saying that. I just, that next time we may have 4 or 5 folks come up saying, hey, we need an extension because of the way our meetings, you know what I'm saying?
at least sounds like they had a change in process there that caused the hiccup.
Right, but I don't know firsthand from all, but I can tell you that was kind of something I had to work with as well. I was used to doing it the way they normally did it. For some reason, the county government, they always want, if you're gonna apply for a grant, even though this is a reimbursement and grant, they want the board to say, give the blessing for you to see those funds.
Recent changes.
So that won't create any issues for y'all.
I think that's the big thing.
Yeah, we all have it.
You know, if it's not gonna create an issue for you, then I would entertain a motion to approve that.
What we don't want to do is do what historically was done in the past that we took us a couple years to clean up, is we don't want to keep extending the deadline for everybody. That's not the way this works. We now are going to be predictable with this cycle so that we'll open it at the end of the year and we'll make it, due. So we hope that when you're staying on the same cycle, future state, regardless of your hiccups, you can comply with this.
So let me ask you this then. So if this is a problem with some of the county agencies, when did we announce this, Brad?
It was the Friday before Christmas.
So do we in the future need to give a bigger window? to
That's what I was
open?
just
Maybe
thinking.
that.
Can we go, yeah.
Because that's usually when they postpone their meeting,
That way they can get on the consent
put them
agenda
all,
for
and all
December.
that left in the.
So first of December.
So maybe do an extension and then moving forward, maybe give a little longer
Maybe
window.
even
to
earlier,
apply.
like, there's no reason we couldn't announce it in November. We know it's gonna come out, or even
That's
October.
good. That way we avoid
Good.
while they're out for the holidays.
There's plenty of time.
Nobody.
It gives them a
Yeah.
chance to get on the agenda and the commission.
Why don't we can also do this might help even more, is, you know how even just like with the, our GAMS colleagues with, conferences and stuff, you put a save the date, we can even start earlier than that with a save the date anticipated grant cycle. And then everybody gets their heads up. You can at least, you might not know how much money it is, but you can get what you want for your equipment on that agenda, whether it's consent agenda or you actually have to present it in front of your county. We'll do that.
Okay.
So there was one other issue that I was allowed to hold up here about how long it took. Because there were several that I'm still concerned about. And it goes back to that 911 versus general transport designation. And I'm still a little bit frustrated. I think we're funding some general transport trucks in this. And after we get finished with this, I'm gonna go back to that and talk a little bit about it. But what I'm interested right now is a motion to approve this or not to approve this exception on the time frame.
Make a motion to approve.
I second.
Have a motion second to approve. Any other discussion? All in favor, aye. Any opposition? Okay.
South Georgia Medical Center has requested a level 30A soft body armor for EMS and RTF to improve safety of EMS providers working on violent trauma calls. They also provided pictures and an invoice.
Some of you tactical people, tell me what's a level 3A.
That's basically. it's like- Did we, wasn't there a group that provided some of these to the services already before with the, I'm just curious, what was that task?
Yeah.
What we call it, our task force or whatever group where we got the kits and the vest,
Mhm.
all the stuff in them. But I mean, I think there's a. You talking about the triage kids? Yeah, the triage.
Either that or the body on.
Yeah, they're looking for ballistic vest here.
This is,
Well, this is probably plate carrier.
yeah,
It is, looking at the picture, that's
it's
exactly.
like the front plate and the back plate.
Okay, get a picture of that.
Yeah, that's plate carrier.
Do I hear a motion?
I'll make a motion.
A motion to approve.
I'll say.
Got a second. And going forward, I tell you, I personally have some angst about this. You're talking about opening a Pandora's box. I don't know. The whole idea was to provide trauma care, provide equipment for patients to take care of trauma. I get it. It's a dangerous world out there. I don't know that that's our role in funding this type of thing. Having said that, you know, everybody gets a vote, including me. Any other discussion?
Those plate carriers, do they have the iPads with them?
No, she did push. Think so.
Because, I mean, just to explain that. If it's. You can put iPads on there, which is a jump kit. So if you have a school situation. The medic's not loading bags and everything's on that bed.
Tourniquet on
That
it.
treats patients.
While it's not included in the pricing of their invoice.
They may already have.
That's what most people are doing, putting that. But So what is it, you know? So-
I will tell you, I go back to this. We got like 16 or 17 agencies in the state of Georgia who have requested the ability to carry extra blood. That ain't one of them. I worry about their priorities. I mean, is what it is. Tomorrow a medic might get killed. I don't know. God, I hope not. I'm not sure that's where I want to go. So. Any
Well,
other
maybe-
discussion?
You don't approve it to add to the list, then, sounds like.
That's we're gonna vote.
Oh, sorry.
That's my belief. It should not be on the list.
So to completely take anything, the body armor off that list that they.
Well, the body armor is not on the list currently.
Well,
Yeah. That's the whole idea here. It's not on the list. They have to request an exception to the list.
It's not equipment. I mean, I'd love to put ballistic stuff on all my people, but that's a grant or that's my expense but that's not trauma care.
Yeah.
That's safety, PPE stuff.
Any other discussion? All in favor be aye. Any opposition, same sign? Aye. So I'm gonna say it fails.
Okay.
Any objection to me saying that? Okay, thank you.
So not approved.
Not approved.
Got it. For Clayton County Fire and EMS, pediatric infant IO equipment needles.
That's already there.
It says adult. It does say adult.
Glad they brought that up.
Okay. Yeah, that should be there.
It should just be, it should just be.
Yeah, just
I actually thought that was on the pediatric equipment list as part of it. It may not have been, I don't know.
Okay, so that's approved.
Would you feel better with a motion and a vote?
Let's go ahead and I'll add it to the list. So there's. no
Well, I would
question.
make a motion that we
You gotta do-
remove adult from the terminology on the accepted list where it just says interosseous needles.
Okay.
So that way, everything's included, pediatric, adult, doesn't matter.
Okay,
Does that make sense?
yes.
That's a better way to.
But how are we gonna do we need to vote for this instance?
Yeah, what we're doing is voting to put it on the list.
Okay.
So going forward, it
Going
will
forward.
not come back in front of us. So I have a motion.
It's just, I'm going to, I'm having more discussion over that topic, but I don't think it's gonna change the vote. I was just trying to say in that same list, it also says adult IO trainers.
Yeah,
Should we change?
Great
I think we
point.
should change that to just say IO trainers as
Yes.
well.
yeah. Just take the adult out and just put IO.
I think that is in the article, though, not the list advice, so we can't change, if we can't change the article, I'll have to open it up and check, we'll just add it to the list then.
Okay.
Sorry. Okay.
So I'm gonna say that Huey made the motion, Scott seconded it to move. Just the way I'm gonna read this is that we're gonna take out adult and pediatric language and just refer to IO needles and equipment.
Correct.
Yeah, there. All in favor, aye. Any opposition, same sign. So that one is approved.
Hey, can you just pause for a minute? Gabby didn't get the count for the body armor for the nay votes, or and it didn't pass, is that correct?
It did not pass. There
was no yays, 0
yeah,
yays.
nobody actually
Okay,
voted in
everybody-
favor of it. So
I'll do it so quickly.
Lucas charged me. Casey. This is an interesting discussion. How many of y'all got Lucas charging cables?
Oh,
They
I
came
don't
with
know.
it.
We already approved this
Yeah.
Based on our discussion.
So Lucas devices are on there, but I just,
It says mechanical CPR is what I think it says.
It says automated chest compression.
Yeah, I'm trying to find the list.
So I stretched system to mean cables are part of the system, so let's just include all of it, yeah.
so how many of you enjoy placing those cables every time the medic gets in a hurry and how many physically poked at one of the striker guys?
But you know, mechanical devices, there's some of them that are contraindicated for.
Oh, yeah,
So really, the Lucas is the only one, if I'm not mistaken, is the only one that's accepted for trauma patients. So I don't know if we need to change the verbiage on that.
I don't know of anybody that has asked for anything else, but
Well, I think
You
one
mean the
reason,
thumper is not still on?
well, I was thinking the reason.
It may be somewhere.
Somebody had a question.
No, I was just saying, I think the reason it doesn't say like Lucas, because that looks like.
Yeah.
we're aided.
Yeah.
Promoting more.
Why don't, could do this since it's on the list and not in the article that is, in the attachment. We could put, we could add the caveat that unless, unless system is
Yeah.
indicated.
Because we, initially the Lucas one was not indicated. That's why we had a big discussion about it some years back.
What did you want to change it to?
Unless, do they need to vote on that unless contraindicated for trauma?
Yeah, would somebody make that motion?
Unless system is contraindicated.
Unless system is contraindicated for trauma patients. Jim, second. Any discussion? All in favor, aye. Any opposed? Okay, thank you. That one we didn't need it, but we did clear up some other stuff. Anything else?
Courtney, I have a quick question on that, and I
Sure.
apologize, I stepped out, y'all may have covered it. But the equipment list for the state changed January 1 with some minor things.
Mhm.
In the past, if it was on the equipment list, it was essentially approved for purchase. Is that not correct?
Yeah.
So do we need to do anything to recognize the fact that the equipment list changed with some minor additions at the first of the year?
Personally, don't think so, because
Okay.
I think our thing references the equipment list.
Right,
right off the
okay.
list.
So, and I don't think y'all are gonna get a request for a screwdriver and some other things that were on there, but y'all know where you can find the equipment list. It's on the state website, obviously. Okay.
Got all of those?
That's all.
And I'll go back there just for a few minutes, because I'm not gonna belabor it too much, because it's already a few minutes after 12. I'm getting hungry. I still have some angst about the trucks that we funded, I think, with general transport trucks. I don't exactly have the answer. I've talked to a bunch of folks, and some of y'all have given me some ideas offline, and I hope to bring it back up at the next meeting. Whether we try to define, and I started trying to do it with the list that they sent to me, how many 911 trucks on average based on per capita. Can we do it that way? Can we do it some other way? I don't know. It puts the state office of EMS folks in a little bit of a bind, because if the vendor's saying, hey, they're all available for 911. Yeah, I got all these trucks out there, and yeah, they're running dialysis patients or they're taking people home from the hospital. But if the world comes to an end and a meteor strikes California, we have a tsunami, then there'll be 911 trucks. I don't know how to answer that. And I'm being a little facetious, but it frustrates me a little bit that is going on. The other thing that I think we're going to get from the ACS report is that we need to focus on rural a little bit stronger than we have in the past. How we're going to do that without people cutting me with a knife, I'm not sure. But we've got a good level 4 trauma center in Randall County. We know how to give blood, and we do all that. So, but I do want to bring up both of those at the next meeting, because I think that's some interesting points.
Hey, Courtney, because I know there were a couple of, when you sent out or whoever sent out a list of services and the numbers back last year, there were a couple in Region 5 that I actually talked to. There were private services, and I just told them the intent of it, and I don't know if their numbers changed up or down. I don't remember. Is that something that those of us that are on, which the majority of us are representing a region, is that something we could go back and talk to the services that potentially have the?
I think it would be great. And again, the reason y'all are here is to give us advice on the trauma commission on EMS. So it won't be just me and Dick and Jim, because all three of us are on the trauma commission. But the other thing is go back to your regions and say, hey, what do y'all think? So please take that concept back. Say, the goal of it is to make sure that we have 911 trucks adequately funded and adequately staffed and equipped to take optimal care of trauma patients. And if we use that money for someplace else, then it dilutes the money that's going to that focus. That makes sense. And ask your people what they think about it. And if they can come up with a better idea to handle that money, you know, I thought about a competitive grant. Problem with competitive grants is it takes a good little bit of work and a good little bit of thought process on how you're going to structure it and how you're going to grade the grant. You know, and not only that, who's going to do it? Because I wouldn't want to do it. We need to get somebody from completely objective to do it. But anyway, all those things are on the table as far as I'm concerned. It's been a good program. From what I understand in talking to the folks, that this is one of the most popular things that we do. But if you're out there and you got 2 or 3 ambulances, you do the math, the amount of money that you're getting out of this program is not going to buy a whole lot. And that might be an area that needs a whole lot. So.
Can I make a recommendation?
Sure.
Talking about the money and breaking it down as such small portions. Why don't we look at in the future, making a pay to play type process? So you look at the service, what are they doing for prevention? That's where it starts.
Yeah.
If they're not contributing to prevention, the only thing they want to do is the transfers to make the money, then you cut them out until they come forward and say, hey, now we're doing stop bleeding. We're doing the bicycle safety, we're doing this.
Participating in RTAC.
Exactly.
all those things.
That's the biggest problem we have.
Did the blood administration training module, 80% of our staff, we have. PVP is like gold. It's the only way to get, I mean, it's how we got the trauma centers really.
It's going. It'll extend out the process because now you're gonna have people having to look into those things and, you know, and follow up.
We got people to do that, Dwayne. Let us handle that. We work happy. You set the criteria and we will make that happen.
I'm all for that, and I may lose money, but the thing is, we're looking at trauma care. And-
Well, I guess, Dwayne, one of the things that, and I've harped on it. You know, we had 2 patients in the last 5 months, I guess now, that if we had not been able to hang additional units of blood between our hospital and Augusta, patients would have died. One of them was a trauma. So boy's gonna have to get him a new girlfriend because the second time he came in shot in the groin. But she's not the best shot in the world either, but she hits something pretty vital. But the other was an ectopic pregnancy, you know, and this lady lived. And if it hadn't been for us hanging extra blood, she would not have. I think the thing that bothers me is that if she had died, everybody would say, well, they did everything they could. Well, no, they didn't. If we had not been able to hang that extra blood, and folks, that is not difficult. That is not high end. I learned to do that in 1976, before some of y'all were gleaming your daddy's eye. Okay. So anyway, but point well taken. I think that's great idea. So do some thinking about that. Immediate transport from non-trauma hospitals. That's something we got to fix. And that's beyond us, because that's going to take money in a lot of different, lot of horsepower and other stuff. Learning management system, I have no update. March pause. And we are, just 2 things, that we are continuing to work on that training program. I have all the equipment. We hope to have the first class in Emmanuel County. We had to cancel it because we didn't get equipment in. Some of the equipment is pretty high end, but everything is in now except for the standalone chest tubes. We can work around that. The other thing that we have identified in our concept of this is to put the medics, the nurses, and physicians in the same room. And one of the concepts that we have recognized from the level 4 things and from the ACS thing is a lot of the rural hospitals don't have protocols on what they do when they get in. And just like with stroke, bang, 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 with STEMI, they have that. And we're working with some folks to try to develop those protocols that as we do the classes, we can hand them the template And so all you really need to do is take this template, put your name in it and take it to your medical staff. Because I don't know how many of y'all work around rural hospitals or any hospital, but it's very, very, a lot of times the nurses won't do anything until a physician orders it. All right, that depends a little bit on the culture of that particular ER. But if the physician's doing something else, or he's napping, or he's up eating, and that trauma comes in, you know, there's certain things that, you know, need to be done. And if the EMS calls in that, you know, he's got a gunshot wound and the blood pressure's, you know, 60/40, let's go ahead and call lab, let's get the blood here, have EMS start a blood set instead of IV set so that it happens quickly. So that concept is being done as we speak. Anything else for the good of the group? Do I have a motion to adjourn? I accept that. Thank you all so much for your time. And if you get back with your group and find some great ideas, shoot them to us.
Yes, sir. Y'all want this? This is the equipment list. I just printed in case. Those any discussion that you want.